Good afternoon, everyone. My name is Maeve Williams, and I'm a project manager at the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure to introduce Dr. Tracie Newman, who will be presenting this webinar titled HPV Infection Immunizing for Cancer Prevention. Dr. Newman is a board-certified pediatrician with a strong background in public health. She currently serves as the medical director of CIRE and is also an associate professor of practice in the Department of Public Health at North Dakota State University. In addition, she is an associate clinical professor at the University of North Dakota School of Medicine and Health Sciences. Dr. Newman, you can go ahead and get started.
All right, thank you so much, Maeve, for moderating and for the introduction. I am excited to talk with you all today about human papillomavirus infection and immunizing as a means for cancer prevention. So we will dive right in. First, we just have our standard disclosure slide, CME statements. I have nothing financial to disclose. And these will be our learning objectives for today. We hope after hearing this talk that you'll be familiar with HPV epidemiology, a little bit of its etiology and pathology of the virus. We're going to discuss some current HPV vaccine data as well as recommendations for its use. And then we'll really end today's talk by focusing on vaccine communication strategies focused on HPV vaccine. So just to start, we know that a provider recommendation has a really robust association with HPV vaccination. For everything from initiation to completion to follow through. There have been numerous studies that have shown that a greater percentage of patients will initiate the HPV vaccine when they receive such a strong recommendation from their provider. So we at CIRE here really believe that provider communication should be an essential part of our efforts to increase vaccination coverage in the United States. So knowing the importance of this provider recommendations, what does the research currently tell us on us as providers? Do we feel prepared to have these conversations? There was a large systematic analysis that looked at actually over 1,000 publications, and it found that HPV knowledge among providers remains low, in particular for things like knowing the HPV prevalence among different populations, providers knowing oncogenic versus non-oncogenic strains of the virus, and then providers feeling knowledgeable about certain head and neck cancers, as well as other HPV-associated cancers. There's other research that indicates that healthcare providers perceived sort of self-efficacy and their confidence in addressing patients' concerns plays an important part to how often and how strongly they're making their recommendations. In fact, one study said that 55% of providers report feeling like there's just not much they can say to change the minds of parents who delay or even refuse this vaccine. And then there's a different set of research that found that healthcare providers say parents worry that vaccination will promote sexual activity, or maybe if they're uncomfortable discussing sex with their children, they really saw this as a significant barrier to this vaccination in particular. However, we know that educational interventions have been shown to be effective in helping providers improve their knowledge and communication with their patients. So let's just start by taking a look at the rates of vaccination among our adolescents in the United States. So when we look at things like Tdap and meningococcal, of course, these are our other two vaccines routinely recommended at this age, you can actually see we're doing pretty well. How about HPV vaccine? What would be people's guess? Do you think rates would be similar to, above, or below what we're seeing for our other adolescent vaccines? If you get, I see a few people guessing. If you answered far lower, you are correct. Coverage with at least one dose of HPV vaccine in the United States actually was around 20 percentage points lower than coverage with these other vaccines, and only half of our adolescents complete the series by the recommended age of 13. So is this a provider recommendation issue? Is this a parent hesitancy issue or other? Either way, this talk today is really designed to just help us feel more confident and comfortable in addressing HPV vaccinations with our patient encounters. And then just sort of a recent update here, this MMWR by the CDC article gave us some additional information. They analyzed data from the 2023 National Immunization Survey. So this is sort of our most recent information in the US. And they found that adolescent vaccine coverage, first of all, was similar to rates in 2022, which is a little promising. But specifically, vaccination coverage for VFC eligible adolescents that stayed generally stable throughout the pandemic, except for a decrease in those that were up to date with HPV vaccine by age 13. So there seemed to be just this one carve out for the HPV vaccine. Some people like to think of this as missed opportunities. So we define missed opportunities as office visits when vaccine eligible patients do not receive a recommended vaccine. This was an interesting study. You can kind of, first I'll just say the data between the dashed lines, that was between March and May of 2020, was excluded just due to an unusually low visit volumes, because this was at the onset of the pandemic. But it's interesting to note, pre-pandemic, we were seeing far less missed opportunities for things like meningococcal and Tdap. Again, HPV did trend much higher, but all of these were steadily declining. We were sort of getting better as providers. Then these began increasing throughout the pandemic, and HPV vaccine missed opportunities remained far above our other adolescent vaccines, and for whatever reason, were increasing sharply. So by the end of today's talk, we just hope that you feel more confident in addressing HPV vaccination with your patients. And the ultimate goal, of course, would be to have fewer missed opportunities. So we'll start a little bit with the epidemiology and pathology of this. A CDC analysis provides kind of the clearest picture of sexually transmitted infections within the United States. Estimates indicate that about 20% of the population, or that's 1 in 5 people, have an STI on any given day in this country. And the cost to the healthcare system is nearly $16 billion in direct medical costs alone. HPV is estimated to cost around $775 million annually. And again, that's just in direct medical costs. We know the total cost to society would be much higher when you factor in productivity losses, our STI prevention efforts, and other non-medical costs. Approximately 42.5 million Americans are infected with HPV, and there are more than 13 million new infections each year. So this just is far outstripping our other sexually transmitted infections. HPV is the most common sexually transmitted infection in the United States, particularly in our adolescents and our young adult population. So you can see current estimates tell us 85% of people will get this virus at some point in their life, and almost everyone who is unvaccinated and is sexually active, again, will get HPV. The good news is around 90%, so that's the majority of these infections, are self-resolving within the first 2 years, but there is this subset of about 10% that go on to cause these longer or chronic infections. And those are the ones we really worry about because they've been associated with certain types of cancer. So a little nitty-gritty about this. This is looking at the HPV genotypes and their disease associations. So this is what we call a double-stranded DNA virus. It infects only humans. There are currently more than 200 types of HPV known, and these get broken down into mucosal or cutaneous sites of infection. Interestingly, the cutaneous sites are what we think of as common warts that we see on the hands and feet. But there are about 40 types that infect the mucosal epithelium, and these are categorized associated by either being high risk or low risk as far as cervical cancer. And I'll just point out on the high risk of these oncogenic types, the ones colored in purple here are the ones that are covered in our current 9-valent vaccine. So every year in the United States, nearly 200,000 women are diagnosed with a cervical precancer. More than 11,000 women are diagnosed with actual cervical cancer caused by HPV, and around 4,000 women will die from cervical cancer. Globally, cervical cancer is the 4th most common cancer in females, And cervical cancer was once the leading cause of cancer deaths in United States women, but due to our HPV vaccines and really our cervical cancer screening, we've now made it one of the most preventable cancers. So again, cervical cancers caused by HPV, these are preventable. And what's interesting is cervical cancer is thought to sort of be the tip of the iceberg, if you will. Although it is our most well-known, there are other types of cancer that are caused by this virus. And vaccination could prevent greater than 90% of cancers that are caused from HPV from ever developing in the first place. So cervical cancer, I would also point out, is our only one that has recommended screening tests for its detection at sort of an early stage. All these other cancers may not be detected until they cause significant health problems. And even with screening, you still see substantial amount of HPV, as we said. There's still an estimated 196,000 precancers each year. And treatment for cervical cancers and precancers may sometimes limit a person's ability to have children or affect fertility. But let's look at some of these other cancers. So every year in the United States, there are greater than 14,000 people with oropharyngeal cancer, almost 7,000 people with anal cancer, 3,600 people with vulvar and vaginal cancer, and then almost 1,000 cases of penile cancer. This is looking at data from 2015 to 2019, and you can see we had a total of greater than 47,000 new cases of HPV-associated cancers. This is within the United States. In women, definitely cervical cancer is our most common, but look at men, you see a substantial amount caused by oropharyngeal cancer. This is showing trends in age-adjusted cancer incidence in the United States. Again, that same from 99 to 2015. And what's interesting is during this time period, you can kind of see cervical carcinoma incidence rates were decreasing each year, and then oropharyngeal carcinoma sort of took the place of that. And by around 2009 or 2010, oropharyngeal cancer actually surpassed cervical carcinoma to become the most common HPV-associated cancer. And since these cancers take time to develop and high vaccination rates were really not reached until about the mid-2010s, it's only now that we're starting to see some of the impact, at least on population level vaccination, which I'm going to show you. During 2012 to 2016, almost 44,000 HPV-associated cancers, so that's about 12.2 per 100,000, were reported annually in the United States, and around 79% of those were attributable to HPV. Of these cancers, an estimated 92% were attributable to strains targeted by our 9-valent HPV vaccine. And again, you can kind of see the largest number were these oropharyngeal cancers, followed by cervical, anal, and others. Again, we just want to highlight that it is known that more than 90% of HPV-related cancers are preventable with our HPV vaccine. A recent study, it was published in fall of 2023, found that almost 1 in 3 men over the age of 15 are infected with at least one genital HPV type, and 1 in 5 are infected with high-risk types. So HPV prevalence is highest in our young adults. Again, this peaks between 25 to 29 years old. So this genital HPV prevalence is high in men, maybe higher than we once thought, and that prevalence remains high throughout their sexual lives. I think results such as these really indicate that men serve as a reservoir of HPV infection, and this just clearly emphasizes the importance of incorporating men in our HPV prevention and control efforts. Kind of a graphic slide, but this is a vaccine to not only prevent cancer, but also disfiguring genital lesions as well. I think sometimes people forget that. A little nitty-gritty about the pathogenesis of this virus. So when we kind of look at what happens, initially the virus is latent inside the epithelial cell, and it sort of has this low proliferation rate. As the virus enters what's called the lysogenic cycle, that rate of proliferation increases. Finally, the viruses are assembled and they're secreted from these keratinocytes to repeat this infection cycle sort of over and over. So HPV infection occurs at the basal epithelium, and although the incidence of infection is high, as we said, Most infections will resolve within a year or two, but this small proportion of infected people become persistently infected. And that persistent infection is the most important risk factor for the development of cervical cancer. So in women, you can kind of see squamous intraepithelial lesions of the cervix can be detected through screening. And so low-grade squamous intraepithelial lesions, those will often regress, but the high-grade ones are considered cancer precursors. And if those are left undetected or untreated, they can progress to cervical cancer years or even decades later. And I'll just point out that the pathogenesis of the other types of HPV-related cancers are likely following a very similar course. And I think it's also important to note that there's been research to show infection with one type of HPV does not prevent infection with another type. So of people that had one strain of HPV infecting their mucosal epithelium, anywhere from 5 to 30% were infected with multiple types of the virus. This is some older CDC data from the pre-vaccine era, just really interesting, showing very impressive lifetime risk of HPV-related pathology. You can see the risk of cervical or oral HPV infection. I mean, 1 in 2, so a 50% chance. 1 in 6 lifetime risk for CIN1, that's that low-grade, cervical dysplasia. 1 in 8 for things like genital warts, and so on. So just really substantial numbers, especially when we weigh this against the risk of any other vaccine preventable illnesses. I think it's important to put this disease and the vaccine in perspective in that way. So we know HPV will affect far more people than did diseases like meningococcus and Hib in their pre-vaccine years, yet these vaccines are readily accepted by most parents. HPV will cause cancer in more than double the number of children that suffered from Hib, and it causes precancer and genital warts in over 100 times more people. So why are we seeing this difference in acceptance of the vaccine? Let's talk a little bit about the vaccine. This is just sort of showing you a timeline of the evolution of this vaccination and our recommendations around it within the United States. This hit the scene in 2006, where it was initially only recommended for females. We routinely gave this at 11 to 12. There was sort of this caveat said that you could give it down to age 9. That wasn't routinely done except in special circumstances. And at that time, we offered, this was a 3-dose schedule, and we offered catch-up vaccines through 26. In 2011, we added boys to that recommendation. This was still a 3-dose schedule at that time. And by 2016, we switched to a 2-dose schedule as long as the first dose was administered before the 15th birthday. And then as of 2019, we are still at a 2-dose schedule before 15. We now offer catch-up through 26. And this has been expanded to this older population, 27 through 45, in this shared clinical decision-making, which we'll touch on a little bit. And then along the bottom, you can see we started with a quadrivalent, so we covered 4 strains. There was also a bivalent vaccine for a period of time, and now we currently have this 9-valent vaccine. The original quadrivalent and bivalent vaccines did pretty well. They covered about 70% of cancer strains, primarily with 16 and 18. The quadrivalent vaccine added strains 6 and 11, which caused most of the genital warts that we see. In 2014, the addition of additional strains now means that 90% of cancer-causing strains are covered. And again, the quadrivalent and bivalent vaccines were phased out in around 2017. So currently, Gardasil 9 is the only vaccine that we have available in the United States. And this was initially approved for cervical cancer prevention distinctly. However, in 2020, the FDA broadened this approval to include oropharyngeal and actually other head and neck cancer prevention as well. And these vaccines are meant to be used prophylactically. Sometimes we get asked this. These are designed to prevent initial HPV infections and thus any of their sequelae I've kind of showed you. There are a few therapeutic vaccines in development, but those are not yet clinically available. So these, those would be designed to sort of induce regression of an existing HPV-associated lesion. And then for patients who've already completed some of our earlier series, maybe the bivalent or quadrivalent vaccine, Again, those targeted most of the high-risk HPV types. Revaccination with our 9-valent vaccine is likely of marginal individual benefit, and we do not suggest doing that. Again, just a slide to highlight that HPV serotypes covered in the 9-valent vaccine account for the vast majority of our HPV-associated cancers. Gardasil 9, these are our current recommendations, is approved for use in both genders, ages 9 to 45. ACIP recommends everyone get vaccinated at age 11 to 12 or as early as 9, and that our adolescents and young adults, 13 to 26, be offered what's called a catch-up vaccine. ACIP now recommends 9 to 14-year-olds receive 2 doses over a 6 to 12-month period, again, instead of that original 3-dose. And then those, if you do initiate the series after 15, currently it's still recommended that you get 3 doses over 6 months. And again, these recommendations are designed to promote immunization when we know the vaccine is most effective. So before the initiation of sexual activity and any exposure to the virus. Those already infected with HPV can also benefit from vaccination just due to the protection against HPV strains not yet contracted. But again, these don't treat existing HPV vaccines. And additionally, we know the vaccine elicits a higher immune response from younger adolescents versus older teens. And then this catch-up vaccination is not actually recommended for all adults over 26. We encourage this shared clinical decision-making in that older age group. So just a note regarding spacing, so something else we get asked sometimes, if the second shot is given earlier than 5 months after the first, that patient will need a third shot at least 4 months after the second dose was given. And again, just to highlight why we changed in around 2016 from the 3-dose to 2-dose recommendation for those children under 15. There were immunogenicity studies that show 2 doses of this vaccine given to younger kiddos at least 6 months apart provided as good, if not better, protection than 3 doses given to our older adolescents. Here's a little bit more. Again, the FDA expanded that approval for now people 27 through 45. ACIP does not recommend routine catch-up for this age group. They do recommend adults who have not been properly vaccinated, who may be at risk of a new HPV infection, talk to their medical professional about receiving a vaccine. So some examples here might include, like something you might consider in the shared clinical decision-making would be younger men and women or those who are not in committed monogamous relationships. At any age, having a new sex partner is a risk factor for getting a new HPV infection, just given how prevalent this virus is. Maybe for adults with more HPV risk factors. So for example, multiple previous sex partners, maybe they have certain immunocompromising conditions, or people who are recently diagnosed with other sexually transmitted infections. They might be someone to consider in that shared clinical decision-making. Okay, we'll stop for a brief knowledge check. So the 9-valent HPV vaccine provides protection against approximately what percentage of HPV-related cancers? A 70, B 80, C 90, or D 100? I'll let you guys think about that. In the interest of time, I will tell you the answer is C. Hopefully most of us got that, 90%. So a really highly efficacious vaccine, which we are going to look at now. So let's look at the vaccine efficacy. We have large vaccine licensure studies showing really excellent efficacy in decreasing persistent infections and the incidence of certain cancers and various diseases caused by HPV. I'll just point out the average duration of these studies was 3 to 3.5 years. These are, large randomized controlled double-blinded trials. So really, really high quality data. And specifically for Gardasil 9, which is what we use now, studies showing 97% vaccine efficacy. Here's HPV vaccine efficacy data. Again, large randomized trials. This one's looking at cervical, vaginal, and vulvar disease. And it's interesting to point out, you can see high efficacy for all the vaccines in HPV naive populations, but you even gain benefit in the overall population from sort of herd immunity concept. So a take-home message we like to say, similar to putting on a bike helmet before you go on a bike ride to protect against head injury, HPV vaccination is really designed and incredibly effective if it's given before exposure to human papillomavirus. The phase 3 trial for Gardasil 9 was actually extended to become a long-term follow-up study, and this was trying to look at the immunogenicity through 10 years or more after the last vaccine dose. So we're starting to get this data now. This was conducted at 40 sites across 13 countries. And after up to 11 years of follow-up post dose 3, there were no cases of HPV serotypes related to high-grade interepithelial neoplasia or condyloma in both males and females. And incidence rates of HPV 6-month persistent infection were also very low in this study. I would point out too, there were no cases of that high-grade interepithelial dysplasia, which we really care about, related to vaccine-targeted HPV types during this for both genders. So pretty promising long-term follow-up. So that was a little bit about efficacy. What does the effectiveness or the real-world data tell us now that we've had this out for a little while? Interestingly, rates of vaccine-type cervical HPV infections and even precancers have declined in places like the United States and various other countries following large HPV vaccination programs. So we have early evidence suggesting that HPV vaccination may be contributing to recent declines in cervical cancer incidence, especially among young females, of course, although further studies are needed to confirm these findings and are underway. In addition, though, lower rates of oral HPV infections have been documented for vaccinated versus undocumented men and women in the United States. Reduction in genital warts has also been observed in years following this vaccine. It's actually predicted that genital warts will be nearly eliminated from Australia as a result of their strong HPV vaccination efforts. In this 2020 study published in New England Journal, researchers in Sweden followed almost 1.7 million Swedish girls. They were between the age of 10 and 30. They followed them through years 06 to 2017. As you can see, over 500,000 were vaccinated with at least one dose of HPV vaccine. And a large share of them, 83%, started before age 17. So they followed them and they evaluated for cervical cancer up to the age of 31. And they compared incidence rates of cervical cancer in the vaccinated versus unvaccinated group. And then they kind of stratified it by age. So they used 17 and 20 as cutoffs for comparison. And you can kind of see the figure in this slide is showing that the cumulative incidence among unvaccinated women just sharply increased compared to vaccinated women. Overall, there was a 63% lower risk of invasive cervical cancer. And if the vaccination was given before 17, it reduced the risk by 88%. And then if it was given 17 to 30, it reduced the risk by 53% when compared to unvaccinated. So pretty good real world data coming out. This was a 2020 Lancet study that showed the HPV vaccine reduced incidence of cervical cancer. Total, it was around 87% in women in their 20s in England. The UK HPV vaccination program, it's very similar to ours. It was introduced around 2008. They give vaccines to girls 12 to 13 with this catch-up offered up through 18. But pretty remarkable results. So if women got the vaccine between 16 to 18, it reduced their cervical cancer risk by 39%. 62% if they got it between 14 and 16, and then 90% if they received that vaccine at the lower age. So again, we know this is most effective when given at sort of that younger age group. And we're starting to see the data again to back this up. This was very recent observational study published last year. This looked at a large data set out of Scotland, and it found no invasive cervical cancer cases were documented in women that were vaccinated at that younger age group, 12 to 13. The Journal of Clinical Oncology recently published a meeting abstract. So I would just say this was not peer-reviewed yet. It was a meeting abstract, but very interesting. It looked at HPV vaccination on the development of HPV-related cancers. So this was a large retrospective analysis. It was done in the United States. And you can see they found 54% lower odds of developing cancer among boys, especially head and neck cancers, and then a 30% lower odds developing HPV-related cancers in females, particularly cervical cancers, but also some other types of cancer and precancerous changes caused by HPV. So these results sort of add to the piling evidence we have for this real-world effectiveness in preventing disease. Some very recent ones, just a few months ago, actually. These were published in the fall of last year. So there was a large cross-sectional study from JAMA Network Open that revealed several counties in North Texas had a higher incidence of HPV-related cancers and lower HPV vaccination rates than elsewhere in the state in comparison. Texas is one of our states kind of known to have very low HPV vaccination coverage and higher rates of HPV-related cancers. So it's interesting to make that correlation. A second recently published study showed that men infected with strains of HPV associated with cervical cancer showed evidence of sperm death and lower rates of fertility. So maybe more to come on that, but some concerning new findings for males. Good news though, HPV vaccinations are associated with reduced cervical mortality in young women. So the flood of data kind of continues. Another study showing the effectiveness of these vaccines in reducing deaths, in particular from cervical cancer. So recommended, if you remember, to only young women in 2006, and now it's recommended to all children and adolescents. These vaccines have reduced deaths from cervical cancer by 62% in young women. This study looked particularly at women under the age of 25 years. And just an update for everyone. So there is this HPV vaccine work group, and it's recently gone sort of a reformation that was announced last summer in the June of 2024 at their ACIP meeting. There had been an HPV vaccine work group that met for previous years, for many years, but it had been inactive since about 2019. And now there's kind of been 3 meetings since July of 2024. They actually, I believe, meet next month in February of this year. But some things that this group is going to start to look at has a lot of people's interest. So one of them is reducing the number of vaccine doses in our current recommended vaccine series. I'm going to show you a little bit more about that, but this group is looking at the effectiveness of just reducing to 2 doses across the board, so not giving 3 in an older group. They're also looking at efficacy data of a 1-dose series, which is being done in some countries. They're also looking to reword some of the recommended age for this. So maybe instead of saying given routinely at 11 and 12 and can start at age, just strictly saying that you start this at age 9, which many groups have been advocating for, including people like the American Academy of Pediatrics and cancer organizations. So more to come on that. They're also going to reword, I believe, part of the shared clinical decision making. If you remember that busy slide I showed you, it's a little confusing, and they may look to rearrange some of the ages in there as well. So a little bit more about this. The World Health Organization actually in 2022 updated their sort of guidelines around this. They showed evidence to support a 2-dose schedule starting at age 9 for all older age groups, which HPV was licensed. And then they said as an off-label option, you can give a single-dose schedule to be used in girls and boys ages 9 to 20. So you can see there's been a number of countries that have already implemented this. So some of the first countries to change to a routine single dose schedule were actually England, Ireland, and Australia. So we are sort of anxiously awaiting some of their data to come out on this. Many countries changed from the 3-dose to the 2-dose schedule for people over 14. We are not doing that yet in the United States, but larger places like the Netherlands and Sweden have done this. So we anticipate some data from there as well. And then this single dose recommendation has also been endorsed by various regional advisory groups like the PAHO and others. So more to come. I believe there's going to be a lot of data presented on this at upcoming ACIP meetings. So again, a little bit more about those WHO recommendations. They currently say 2 doses for people 9 and older with an option for a single dose HPV vaccination through the age of 20, except of course for people immunocompromised. There are separate recommendations for that. And I'll just say there are some randomized controlled trials in numerous countries currently being carried out around this. There's a very large trial in Costa Rica, as well as one in Kenya. That's going to go through 3 years after vaccination and looking at some of the efficacy. So more to come on that. Let's switch gears a little bit to look at our HPV vaccination rates in the United States. So this is showing nationwide 1 or more doses for our adolescent range as of 2022. You can kind of see we tend to do a little better in the Midwest, places like Minnesota and others compared to maybe our southern states. Very similar pattern when you look at up-to-date or series completion for our adolescents nationwide. And we know that having 1 or more HPV vaccine doses in rural areas compared to urban is consistently lower, as shown in the red line here. This is actually true as a whole in our country. It might not be true everywhere. This actually does not stand true in North Dakota. We do fairly well, but generally speaking, this tends to be the case. And again, various groups have sort of supported moving this HPV vaccine initiation to age 9 to improve their coverage. Sanford as a system actually has moved to adopt this practice in an effort to increase series completion by that age of 13. Why this shift? In 2022, there was sort of this new data that came out. There was the CDC and MWR that showed for the first time ever since this vaccine had been released, we did not have an increase in vaccine rates for our adolescents. And that got a lot of people's attention. They did various surveys about this, trying to figure out why. And that year, just about 1/3 of children in our country who were eligible got 1 or more vaccine doses. And you can kind of see the breakdown of who was doing that. But interestingly, this survey responses also really suggested that for parents who remain hesitant about HPV vaccine, having providers reframe this discussion around cancer prevention could really improve our uptake. So that's kind of been a recent push as well. Again, I've told you in 2018, FDA expanded the age range, so we now offer this to 27 to 45. However, only 16% of US adults in this age group have received an HPV vaccine. Of that percentage, you can see women were 3 times more likely to get this. We saw lower rates in men, in the Hispanic population, and in those with less education. And so it's really thought that low uptake in these types of demographics is concerning for our cancer prevention efforts. Perhaps they should be targeted specifically. Okay, we'll kind of end today about looking at what are some of the barriers to vaccination and how can we overcome some of those, maybe as providers. What are some of the top reasons why parents refuse the HPV vaccine? These researchers out of Johns Hopkins found that safety was a top concern for parents of girls, while lack of necessity was the highest for parents of boys. Other issues you can see, lack of knowledge. I would point out absence of a physician recommendation, and then parents just assuming that their child was not at risk or was not sexually active. That's a common one I hear as a pediatrician. This is interesting. So overall, parental HPV vaccine hesitancy was actually decreasing by about 5.5% annually between 2010 through 2012. We were seeing higher uptakes, and then it remained stable for about a 9-year period through 2020. But again, the 5 most frequent cited reasons for not intending to vaccinate: not necessary, safety concerns, that lack of a recommendation is a big one, lack of knowledge, and the proportion of parents citing safety or side effects as a reason was really significantly higher and increasing the quickest. You can really see it shot up between like 2010 to 2018. So this is another interesting, I guess, concept, like rises in parental vaccine hesitancy observed during the pandemic. We know are threatening public health, and this is continued. This is especially concerning for our vaccines not typically required for school entry. So maybe the COVID vaccine, HPV vaccine, and others. Both of those in particular have lower rates of completion, compared to our other adolescent vaccines. So are we seeing a rise in HPV vaccine hesitancy post-COVID-19 pandemic? I think it's an interesting question, and the current data suggests maybe. I'm happy to go further into this. I believe we have some slides on these trials, but there is some data recently out of Massachusetts that showed somewhere around 11% of pediatricians there reported feeling higher levels of HPV vaccine hesitancy compared to pre-pandemic. But a different set of data out of Alabama showed COVID-19 vaccine release did not significantly impact subsequent HPV vaccine decision making. So hopefully more to come on this. Hopefully people will continue to look at that. I don't think there's a clear answer. All right, so a little bit about communicating about this vaccine. When it comes to vaccine hesitancy, we know the one-size-fits-all approach just is not going to be effective. There are too many varying and ever-changing really concerns that are patient and family specific. When we think about our patients' hesitancy, or even our own, towards making a health behavior change or accepting a vaccine, we'll often find ourselves on this continuum of resistance or this motivation to act. And so you can basically split people into thirds on this spectrum. On the left, we have patients who are not hesitant, right? They call our office to schedule their appointments, they listen to our recommendations. These are families that get their flu shot every year. For these patients, we want to use a more direct or presumptive approach, which I'll show you. On the other end, kind of the far right, we have patients with low motivation to accept a vaccine, or they're highly resistant. Generally, I encourage spending very little time at either end of this spectrum. But then there's this movable middle where I think most patients fall. When we notice that there's some hesitancy or some ambivalence, we need to sort of switch gears as providers and start using some basic motivational interviewing skills. When MI skills fail, we just then want to rely on building trust and expressing empathy. The bottom line is to try and always preserve your relationship with your patient and to improve that relationship where possible. So I sometimes say, you may have to switch gears, and what is your end goal? The end goal might not be that the patient gets that vaccine that day, but the end goal is that you maintain the relationship, and it's something you can broach at a future visit. But we're going to start on this end with presumption. So a healthcare provider recommendation is one of the most potent tools we have for increasing HPV vaccination. Until we notice any signs of hesitancy, we just generally recommend starting the vaccine conversation with this presumptive approach. This has been correlated with increased vaccine acceptance, especially compared to this more precipitory language. So an example might be, your child needs the MMR and varicella vaccines today. That would be presumptive approach compared to more precipitory, are we doing shots today? Studies show that parents who receive clear recommendations for the HPV vaccine, they actually have around a 10 times higher odds of getting their children vaccinated. So you would think such recommendations are common, but they are not. Many parents never receive a recommendation, and most that do often get one that's maybe hesitant, or it's unclear, or it's late. And the main reason for these low quality recommendations, again, includes providers just sort of tendency to underestimate the value that parents are placing on this vaccine, and maybe their expectation that talking about this will be uncomfortable, maybe it'll take up too much time during the visit, things like this. I always say on this site, there was a national study that looked at US adults that 2/3 of US adults who received a provider recommendation to get the flu shot went ahead and received that vaccine the next year. And then it was like 84-85% of those who didn't get a recommendation remained unvaccinated. So I think what we are saying in these visits really matters. When we look at the announcement or that presumptive approach versus conversation approach, you can just see that announcement often results in higher vaccine efficacy. This was data published in Pediatrics, specifically looking at HPV vaccine. And there's now data coming out to show parents are much less concerned than we as providers think they are about immunizations. Here we can see providers underestimated the importance of vaccines to parents, and they actually overestimated parental concern regarding the number of injections. Parents actually rated disease prevention higher than injection number when making their vaccine decisions. And in this study, at least, providers underestimated how important vaccines were to parents across the board in every category. So what are some advantages of the presumptive method? Depending on when you maybe trained or went to medical school, this can make some people uncomfortable. But for starters, it works. It's been shown to improve vaccine acceptance, as I've shown you. This is kind of similar to when we make recommendations for other things in medicine, right? Like your child has strep throat today, I'm going to prescribe an antibiotic called amoxicillin to treat it. You wouldn't say, your child has strep throat, do you want them to have amoxicillin to treat it? And then finally, this approach saves time, which surprises some people. Okay, so based on this information we just covered, would you think this is a positive or negative patient encounter? Provider says, since Anders just turned 11, he needs a tetanus booster, a meningitis shot, and a meningitis shot, which are required for 7th grade. He can also have the HPV vaccine if you want him to have that too. Mom says, we'll take the tetanus and meningitis. We will skip the other one. 3 shots is a lot. Yeah, so this was not an example of effective communication. We never recommend parsing out certain vaccines when discussing with families. So I've kind of showed you that Tdap and meningococcal are usually well accepted as part of the adolescent visit. And so studies really show if we could capture HPV at this opportunity, our vaccine rates would be substantially higher. So providers can kind of normalize the HPV vaccine by sandwiching it in between these other 2 readily accepted vaccines. So Susie is 11 years old today. She is due for vaccines to prevent whooping cough, HPV, cancers, and meningitis. Just kind of leave it at that. So we'll revisit this. This time provider says, Anders is 11, so he is due for his tetanus booster, HPV, and meningitis vaccine today. Do you have any questions? This time mom says, no, that sounds good. So this was an example of a solid presumptive recommendation. It was made with confidence, which often will instill confidence in our patients. A brief knowledge check once again. Which communication approach is recommended to start discussing vaccines before you notice any hesitancy? I'm seeing some answers. Just trying to be aware of time, but I hope I've convinced you it is presumptive. What if presumption doesn't work? Increasingly, that feels to be the case for some of us. So let's talk about what motivational interviewing is briefly. This is by no means meant to make you an expert on MI, but I just want to introduce it to you and maybe show you how you can use it. This was developed in the early 80s by a clinical psychologist. It was initially used as a brief intervention tool for problem drinking. It's patient-centered. It's sort of a guiding communication style designed to enhance a patient's own motivation for change. And it's meant to explore and maybe resolve their own hesitancy or ambivalence. So ambivalence has to be there for MI to be the tool that we kind of want to use. It's been used in a variety of clinical topics, things like substance use, weight loss, blood pressure control, and many others. And it has been shown to help address vaccine hesitancy as well. So again, this is really just about helping people explore their own hesitancy. So if someone is in this movable middle or they're showing you that they're kind of not sure, we would recommend pivoting to more of an MI type approach. So what does that look like? Here's some examples of MI communication techniques. We want to use open-ended questions. We want to try and reflect back what we're hearing. We want to then honor their hesitancy. Then we go on to ask permission to share. From there, we try to make a strong recommendation backed by data or evidence. And then ultimately, we want to support their autonomy. I'm going to show you some examples of this. Another MI technique is using what are called these scaling questions. So for example, on a scale of 0 to 10, how important is it for you to get the HPV vaccine today? You can kind of use that ruler at the top. If a patient reports being 0 to 3, we recommend a pretty limited intervention. If they report being 4 to 10, a provider can elicit the patient's motivation to change. So maybe asking things like, okay, why did you say a 5 and not a lower number like a 4? Or what would it take to get you to a higher number like a 6? This sort of enables the patient to consider within themselves their concerns and maybe their motivating factors for change. Another technique is sharing information with patients using this EPE or elicit, provide, elicit. The general structure of this is to just first find out what the patient already knows, maybe what they've already tried or what they want to know the most about, kind of learn where that patient is at currently. Once you know your starting point, you can ask the patient if you can share your thoughts. It's really important not to steamroll our patients with data. You want to honor their concerns, find out where they're at, make sure your patient is on board with the conversation before you move forward. Once you have that permission, you can share recommendations and thoughts on the topic. And then finally, don't forget to kind of check back in after you've shared the information, eliciting their response. So we'll kind of walk through this a little bit. Here's a case example. Julie is in with her 11-year-old daughter, Carly. They're here for a sports physical. They are regular known patients of yours. Historically, they've been receptive to vaccines in the past. Provider says, great to see you, Julie. I see we have Carly in for a sports physical today. As part of her visit, she's due for Tdap, HPV, and meningococcal vaccines. Any questions? Mom says, I'm just not so sure that Carly should get the HPV vaccine. I've done some research online and I'm worried about how safe it is. I read it may cause something called POI, which can affect her ability to have kids. Provider says, you aren't the first parent to come to me with that concern. Can I share some information with you? Sure, says mom. So a couple of things, I think the provider did a good job of sandwiching the HPV vaccine to normalize it. Once mom expressed some hesitancy, the provider made sure to lead with empathy and really honored her autonomy. She asked permission to share some information, which mom was receptive to. So behind the scenes, you might be reviewing some facts. So let's kind of review some facts around this. Again, to reiterate, the safety of this vaccine has really been a top concern for a lot of parents. So remember, when you're responding to Julie, you want to be clear and concise and try to avoid data dumping. But for our own knowledge here, over 1 million doses have been administered in the United States. Gardasil 9 was approved in an FDA in 2014. The safety of this has been well studied. All of these vaccines went through years of extensive safety and testing before they were licensed by the FDA. And this, Gardasil 9 in particular was studied in more than 15,000 women and men. Vaccine safety actually continues to be monitored after it's licensed through our numerous vaccine safety monitoring systems that we have not only in the United States, but globally. And then I often like to acknowledge some common side effects like pain or redness or swelling in the arm where the injection is given. But let's specifically dive a little bit more into this concern about POI. So one of the key concerns has been that the HPV vaccine is associated with infertility through primary ovarian insufficiency. This claim surfaced in 2012 from an anecdotal case study from a 16-year-old girl who developed this after receiving HPV vaccine. And then a number of other case reports followed, comprising 5 additional cases. Unfortunately, case reports like these sometimes gain an amount of attention in the press and on social media that does not always correspond with their scientific significance. And we actually still see and hear about this association on the internet. So just a reminder of what POI is. It's also known as premature menopause. This is a condition where a female's ovaries stop functioning prematurely. Healthcare providers often do not know why this occurs. I've listed some reasons why. It might be genetic, might be due to chemicals or treatments. There is this other thing where it might be just idiopathic, and so that kind of leaves a void for people to fill that this could be caused by the vaccine. But there is no evidence to prove that the HPV vaccine causes this. To address this correlation or supposed correlation, CDC and FDA have reviewed reports of POI in both VAERS and our vaccine safety data link. What does the research show us? In the interest of time, I'll just tell you there's no association, basically. They've looked at this over 12 years in large data sets. A 2018 study from our VSD involving over 200,000 women did not find any increased risk of this following HPV vaccine. And while there's been some anecdotal case reports, we really didn't have a randomized controlled trial until about 2021. This was a retrospective cohort, that was published in JAMA, so not a randomized controlled trial, but it used nationwide data set looking at almost 1 million Danish-born girls through age 11 through 34, and this found no association between these two things. So pretty promising, large data set. The World Health Organization and its advising committees, they still do not support, any association between HPV and POI. The current safety profile is thought to be very safe. So that's not just the United States, but worldwide. So quickly back to our case. I'm aware we are running out of time here. Provider says HPV vaccines have been around for a long time, now over 15 years. During this time, over 100 million doses have been distributed in the United States. We have very promising and reassuring data that these vaccines provide long-lasting protection and that they are very safe. The rumor that this vaccine causes infertility still makes the rounds on social media. What I hear you saying is that you are concerned this vaccine may cause infertility or specifically POI. Mom states yes. So again, I think this is great. She's showing she's actively listening. She's leading with empathy. She's using clear and concise information. So she goes on to say, as part of ongoing safety monitoring of HPV vaccines, researchers have taken a look at the risk of POI following Gardasil 9. Many studies looking at hundreds of thousands of girls have found no link between these two. Some of my patients do experience some soreness, swelling, and redness where the shot was given. This can be common and is usually self-resolving in a day or two. But do you know what is absolutely linked to infertility? HPV cancer. So the fact that they can cause issues with having children is unquestioned in the medical world. I vaccinated my own daughter against HPV, and I highly recommend Carly get vaccinated too. Then she ends by saying, what stands out to you about what I shared? Mom responds, no, that makes sense. And I guess I hadn't realized that HPV vaccination had been around that long. I really appreciate you taking the time to talk to us about it. Your recommendations are important. I think we're going to take some time to think about it. Provider says, of course, can I send some resources home with you to look at? I think this is an important part of keeping Carly healthy. Can we readjust this at our next appointment? Mom replies, absolutely. So again, what to do when a patient declines? I would just ask to readdress at a future appointment. You want to lead with empathy, honor the patient autonomy, and then maybe provide some homework or some resources for them to look at. I believe here in the interest of time, I'm going to skip over case study number 2. If you're interested, this was a dad who was concerned about giving it so young, starting at age 9. So we reviewed all the data to date looking at that, the various groups that recommend that. And then in the end, in this case, dad was receptive to getting his son the vaccine. So to summarize, HPV infection, it remains a major public health threat. We have vaccines available that are safe and effective. Our vaccination rates remain suboptimal. However, your recommendation can make an impact and improve our rates. And we ultimately want to reduce missed opportunities at our clinic visits. HPV vaccination starting at age 9 to 10 is very promising. We are anticipating more data coming on this very soon, if not some recommendations around that. So I will, I don't know if we have any time made for questions, but I'll just show some acknowledgements from my team at CIRE that helped put this slide together as well.
Yes, thank you so much, Dr. Newman. So first question here, are there any behavioral change models that correlate increased HPV vaccination uptake with decreased overall STD rates?
That has been a great question. That has been looked at in other countries. And on one of those slides I showed, I won't take the time to go back. I feel like I pulled a bunch of data from endpoints of HPV. I only highlighted in this talk the decreased rates of pre-cervical and cervical cancer, but a number of different outcomes have been looked at, including other sexually transmitted infections. And yes, those have been shown to decrease when populations have introduced HPV vaccination programs. They've also looked at things like teen pregnancy, various other, I think, outcomes to see if the vaccine plays as a variable in any of that. But I do believe there's data to show that, not in the United States that I'm aware of.
Thank you. Here's some more maybe clinical practical questions, but if you got a complete series as a teen, do you need to repeat as an adult?
Currently, no, there's no recommendation for that, including, like we said, even if you received the previous either quadrivalent or bivalent vaccine, we actually don't recommend receiving a new series with the 9-valent. It's thought that that protection is long lasting and covered, 70% or more of the cancer causing strains. So.
Wonderful. Thank you, Dr. Newman, again for presenting this webinar and for answering all of our questions today. And thank you for everyone who was able to attend and stay on this long. And we hope to see you at our next webinar.
Yeah, thank you for being so engaged. That was great.
Thank you for watching the recording of HPV infection, Immunizing for Cancer Prevention. This session was presented by Dr. Tracie Newman on January 29th, 2025. For those seeking CPE credit for watching this webinar, and for clarification, this is only for pharmacists and pharmacy technicians, please follow the details on the screen.